Moving on, something you can take to heart, cardiovascular disease. Shorter CAG repeats associated with more severe coronary artery disease, but not more severe risk factors. So they don't have worse cholesterol, they don't have worse blood pressure, they don't have worse insulin sensitivity, higher A1Cs. As far as prostate health, this is probably the most significant data to date, at least where most of the research has been done. We have 3 studies here that all seem to sort of point the same direction. And this is looking at risk of prostate cancer and risk of BPH, or benign prostate hyperplasia, prostate growth.
Yeah, this is one of the most significant effects based on human data. So this is a concern for anybody with few CAG repeats, that you're at higher risk of prostate hyperplasia at an earlier age. And given that we know that something like 50% of 80-year-olds and 90% of 100-year-olds have prostate cancer, it's a matter of time. You don't want it to grow too fast. Again, you think about not just total androgen pool, but total androgen pool in the context of your androgen sensitivity in the prostate. And if that cancer will grow so fast that it's not able to have checkpoints and you're worried about senescence and essentially you're worried about prostate cancer growth. I know I'm certainly worried about prostate cancer growth. The first time we filmed this podcast, it went into a huge rabbit trail, so I'll try not to do that. But that is one of the delineating factors for CAG repeats. And if you look it up in, that in the clinical literature, that's one of the main things.
Yeah, so it's not the end-all be-all of will you develop, prostate cancer, or will you develop an enlarged prostate with time. There's a lot of factors that go into that. A lot of these patients are obese or have diabetes, insulin resistance, and that insulin and those growth factors are feeding the growth of the prostate. Mm-hmm. Perhaps these people have sleep apnea, and that's why they're having to also get up and urinate at night. So there's a lot of moving parts there.
There's a 50% chance I have my mom's dad's X chromosome and a 50% chance that I have one of my mom's X chromosomes. So you should do some math and look at what that individual's prostate health history is. And that's a pretty good estimate. And same thing for the effects on the scalp as well.
Yeah.
It's probably one of the better arguments regarding the genetic basis of you get the hair of your mom's dad.
Yeah, it's certainly plausible. Again, multifactorial sugar-sweetened beverages, all bets are off. That's associated with hair loss.
Yep.
I won't say too much, but we should tax them more. They should be more expensive.
People love it when we say that.
Yeah. Moving on, something you can take to heart, cardiovascular disease. Shorter CAG repeats associated with more severe coronary artery disease, but not more severe risk factors. So they don't have worse cholesterol, they don't have worse blood pressure, they don't have worse insulin sensitivity, higher A1Cs. But with the same risk factors, you see a higher, max percent stenosis, total stenosis score, CAG Repeats. And this is something that you can sometimes see this in high androgen exposure.
Yep.
At younger ages, people with extensive coronary artery disease.
Dallas
McCarver, for example. But not every bodybuilder gets coronary artery disease. And there's sort of a mystery protective factor that maybe 5% of people have, where they have clean coronaries despite all these risk factors. You'd expect them to develop heart disease. But I'm not going to bet my life that I'm in the 5%. I consider myself at probably the 95%.
Yeah, the 5% that have piana man genes, probably not worth betting on that. But yeah, again, thinking about the mechanism of action of why that happens, if cholesterol and the other factors are the same, it's not due to an androgen's upregulation of HMG-CoA reductase. Again, all androgens are reverse statins. So if you were on an androgen, you were on a lipid medication. That's the public health. Do with that information what you will. That's the public health knowledge for today. But it will also, I think about the sympathetic input or the fight or flight input on the heart, especially if your total androgen pool plus your sensitivity to the androgen, your sleep is worse, that there's more coronary artery disease, and then your chronotropic input, your heart is beating faster, more relative ischemia.
Yeah, that's a good way to look at it, because that parasympathetic balance is very important. And we know things even like chronic work stress are associated with heart disease. Certainly more sympathetic activity is going to move things in the same direction. And then with bone, again, This is something that we kind of have talked about in the past with SHBG and then free testosterone versus total testosterone. But also with CAG repeats, it looks like when people have a longer CAG repeat, that they are potentially getting less androgen activity at the bone, perhaps less long bone growth in puberty, perhaps less net bone density or lower peak bone density.
Yeah.
I think this is something that can probably be outweighed by heavy training over a long period of time with axial loading, applying a lot of stress to the muscles and the femurs.
Yep.
Not in terms of growing the bones longer, but in terms of getting the density to a higher peak. But yeah, I mean, and we know that it's not just the estrogen, which we think of women, menopause, bone loss, and hormone replacement. Again, that's depending on if you're the USPSTF or if you're someone who gets the DEXAs on these patients and measures them year after year. You have some very different opinions there.
Yeah.
But testosterone independently has some effect on bone density.
Yeah. Our first shoot of this podcast, we talked quite a bit about Turner syndrome. It's very interesting because it's just one X chromosome, but females, if you will. And it's not uncommon, or previously it was not uncommon to use strong androgens, even synthetic androgens, to help grow long bones during puberty, during childhood. Not done as much anymore, but it was certainly very efficacious to do that. And again, one X chromosome, so one CAG repeat. So likely the efficacy of that was largely dependent on just which CAG repeat length an individual with Turner syndrome happened to get on their one X chromosome.
Yeah, and we know that the testosterone, is testosterone by itself, minimal conversion to estradiol. So if you use a testosterone patch, even in normal testosterone individuals, so testosterone levels below 450, which a 450 testosterone level, a lot of people aren't going to look twice at. It's considered very normal. Even at that level, a testosterone patch that doesn't convert much to estradiol is going to have a positive impact on the bone mineral density.
Yep.
So again, reinforcing kind of what we see with androgen activity equals more dense bones.
I heard that you lose all of the benefit of all hormones within a year or two after you stop all those.
You actually lose all the benefit of a lot of the healthy things you do within a time period after stop doing that thing.
Mm-hmm.
Why use many word when few word do trick is what I kind of felt like I was saying there.
Yeah.
But
one thing that you can keep in mind when thinking about that is there's no such thing as exercise in a pill, but if someone has very low testosterone, whether a female or a male, more androgen tends to help effort feel much better and will also help give them the tools to develop a movement pastime to last a lifetime, hopefully axial loading, which is particularly beneficial for bone density, regardless of what medication or supplement regimen they're on. So that's kind of an aside. One other thing that came up that's not in our template here, but I wonder about the effect of CAG repeats on thromboxane A2 activity.
I would speculate that lower CAG repeats would increase that. So maybe that's where that coronary artery disease, again, we don't know outcomes, but if you are more procoagulatory with
stickier platelets.
Yeah, with a lower CAG repeat, then you would expect an equal amount of testosterone, more of that thromboxane A2 activity.
Yep. Thromboxane A2 is basically just making platelets stickier. And we do know that even compared to individuals with normal testosterone, if you castrate males, in this study, they had to castrate males because of prostate cancer, or they ended up, benefit outweigh the risk, whatnot. Individuals that are profoundly hypogonadal have much less sticky platelets, less thromboxane A2 activity than eugonadal.
Yeah. I think we recorded that podcast quite some time ago. So if you're a listener and you're like, oh, I remember when they talked about that, thank you for being a loyal listener.